Buka salam tamu di sini.
Turn off your video, and if you have any questions, please raise your hand and type it in the chat box. It will be addressed to the speaker by our moderator. So for our next topic, we will be discussing on how to approach postmenopausal bleeding. So it will be given to us by Dr. Azura Mohamad. She graduated from Trinity College Dublin in 2008 and passed her MRCOG exam. And now she is a trainee in Gynaecology subspecialty at Hospital Sultanah Bahiyah. So please welcome Dr. Azura.
Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon to everybody. We are drawing close to our final part of the day before lunchtime. So in lieu of soft voice of ladies here, I'm given the mic to make sure that you can hear me very well. As Dr. Kaur mentioned just now, I'm a gynaecology subspecialty trainee year 1, so quite new to me. So just bear with me while we are doing this presentation. So we're going to touch about how to approach postmenopausal bleeding. First things first, let's see what we are going to do. Just give me a minute. So the apologies for the technical error now. Just now the slide just wouldn't want to move for me. So let's move on to our objectives. We will go through our definition of postmenopausal bleeding, followed by outlining what are the differential diagnoses for postmenopausal bleeding, a bit about endometrial cancer and stepwise approach to postmenopausal bleeding, and some topics that we should cover or make sure that we realize that there's current evidence about what to do with recurrent postmenopausal bleeding, asymptomatic thickened endometrium in postmenopausal women, and inadequate endometrial sampling. So a little bit about background before we move on to our big topic. Postmenopausal bleeding we can define as bleeding from genital tract for two categories of this woman. The first one is at least more than 12 months after last menstrual period in those women who is not on HRT or hormone replacement therapy. And the other one is unscheduled bleeding while one woman is on hormone replacement therapy. So we also are going to include about new postmenopausal bleeding, where this woman represents with postmenopausal bleeding after 12 months of initial presentation and management of their initial postmenopausal bleeding, where recurrent postmenopausal bleeding we define as representation of the postmenopausal bleeding less than 12 months after initial presentation or investigation. Now, postmenopausal bleeding affects 10% of our population, so it is a huge burden to clinic kesihatan and us alike in tertiary centres. So it's something that we need to make sure that we don't miss the big things, which mainly endometrial cancer or other gynecological malignancies. As we can see on the slide, is the bottom one is the sample of uterus been after hysterectomy that's been cut into half. And we can see there's endometrial cancer, frankly, within the endometrium, which from the gross histology would show less than 50% involvement of the myometrium. While the top picture would be the benign pathology such as endometrial polyp or pre-malignant endometrial hyperplasia. So we're just going to recap about endometrial cancer. 90% of these women would present with postmenopausal bleeding. And there are two types of endometrial cancer that we know of. The type 1 would be the one that would be exposed to exposure to unopposed estrogen, and they would present with risk factors such as obesity, diabetes, nulliparity, and hyperestrogenism. And the type 2 endometrial cancer would be the ones that has no associated factors with predisposing factors as in the type 1. These women are the elderly, thin, and has poorer prognosis. So these are just the stepwise approach to postmenopausal bleeding. I'm sure every one of us would be quite well versed about this. Basically, we just need to establish what are the risk factors that I've just entailed just now in the previous slides. So we're going to establish about clinical evaluation of their history, mainly age, parity, use of any hormonal treatment, tamoxifen, obesity, diabetes, hypertension, and followed by physical examination to further establish whether they have frank cancer elsewhere, such as breast cancer, that would be metastasized to uterus, causing endometrial postmenopausal bleeding. And imaging would be something that we would do mainly in our setting, but I just come to realize that only certain clinic kesihatan has transvaginal ultrasound scan. So my slide would be mainly be talking about transvaginal ultrasound scan findings, and followed by endometrial sampling in patients with endometrial thickness that is significant to be biopsy. And obviously after that, depending on the endometrial sampling result, we will treat the cause accordingly. So imaging in postmenopausal bleeding, what we do is we measure the maximum anterior-posterior thickness of endometrium echo on sagittal view of the uterus. I'm going to have some pictures after this slide, so just bear with me about what we are going to define for now about what's significant in imaging for postmenopausal bleeding. Endometrial pathology is found in about, when we take cutoff of endometrial thickness about 5 millimeter, at least 60 to 80% of women with endometrial thickness of 5 millimeter or more will have some kind of pathology, and only 3 to 14% of those with endometrial thickness of less than 5 millimeter will be having some pathologies. However, transvaginal ultrasound is not for everybody. There's some women would have axial uterus. Obviously, the ones who is obese might have difficulty with accessing, we might have difficulty with performing transvaginal ultrasound in this woman. And if the uterus has coexisting pathologies such as fibroid or adenomyosis, the transvaginal ultrasound might be difficult in this situation. And just to bear it in mind, when we see endometrial fluid in the scanning of the transvaginal ultrasound in this woman, we should not include the endometrial fluid in the measurement of the endometrial thickness. So we'll move on to these 4 transvaginal ultrasound pictures. I think we would learn better when we see pictures instead of some text only. So we'll move on to the first one on the screen on the left side at the top left side. Okay, so the one that shows endometrial thickness of 9.5 millimeter. Obviously, if you see this endometrial thickness of 9.5 millimeter, the finding will be significant. So this woman will be subjected to or has to go through endometrial sampling. So that picture, if you can see my arrow on the screen, yes, yeah, no, yes. You can see that the measurement of the endometrium is taken by aligning the uterus at the sagittal view. So you would have to include the endometrial cavity, endocervical canal or cavity right up to the endometrium at the top, at the fundus. And you would, in a normal patient where there's no pathology, you would definitely see the trilaminar view of the uterus. That would be indicating that you are definitely at the sagittal view of the uterus. Okay, so the next one at the corner on the right side of the screen is a different pathology, as we can compare to the one that I've shown just now at the top corner on the left side. So the endometrium on the right side is looking abnormal. As you can see, maybe we may not be able to appreciate that line that we said just now from this endocervix up to the fundus, but you can see the outline of the uterus there from cervix up to the fundus in one whole picture. So we can almost certain to say this is a sagittal view of the uterus. So we have to measure the endometrium at the fundus area. So you can see now, compared to the trilaminar view on the top corner on the left side of the screen, this picture on the right side at the top shows there's some cystic features of these little black areas that might and mixed up with the increased echogenicity of the rest of the endometrium, which might be suggestive of endometrial hyperplasia of some description. And obviously, if you can see instantly, even without measuring the endometrial thickness, this would easily be at least 1 centimeter. And then we move on to the picture on the corner on the left side at the bottom. Rarely we can see endometrial polyp, but this is one of the best picture that I can find on the internet. So, courtesy of internet, you can see as we align the uterus from the endocervical canal going up to the fundus of the uterus, we can see there is an almost well circumscribed longitudinal structure right at the fundus, where you can almost see that even at 2D view, this is something of circular, if not longitudinal, shape called endometrial polyp. And we move on to the one at the bottom on the right side of the screen, where again we may not be able to appreciate, but there is supposed to be a line from the endocervix up to the fundus, and then we can see how disrupted is the endometrium at close to the fundus, with mixed echogenicity between hyperechoic and hypoechoic, which is strongly suggestive of endometrial cancer. So sampling can easily be done at many levels. Here we'll do PPAR biopsy as first line. Obviously, historically speaking, we used to have to subject women to dilatation and curettage. However, this is something of not in favor anymore now, because we have to use the local regional anesthesia and have to allocate operation time for this woman. So it's not going to be a viable option nowadays as first line investigation for postmenopausal bleeding. So for PPAR biopsy, there are many research to say it is more cost effective compared to DNC. Obviously, because there's no OT time to be used, and it is equally as good to diagnose endometrial cancer compared to DNC itself. However, as it depends on how the PPAR biopsy is taken, and there's some limitation for PPAR biopsy where if the cancer is only a very early, where it occupies less than 50% of the surface of the endometrium, the cancer might be missed in this situation. So the picture on the right side is the example of how you take the PPAR biopsy. Basically, you need to do, ideally you should do the speculum to view the cervix, but in some rare situations where we have no access, or the vagina is so stenosed that we can only introduce 2 fingers. So what we do is, in this ideal situation where you can put the speculum, you should view the cervix. Then you would introduce the PPAR biopsy as close to the fundus as possible. Remember, we say just now in the imaging when most of the thickened endometrium would take place in the fundal area, so try to go as far as possible. Now, obviously, reassure the patient that there will be some kind of discomfort caused by this PPAR biopsy being undertaken to them. So then, once you happy to say that you are at the fundal area, then you can withdraw the piston and do your circular motion of the PPAR biopsy as you withdraw out towards the internal parts. And another way of doing endometrial sampling is by us, where we can do outpatient hysteroscopy or inpatient hysteroscopy. So these would be reserved for patients who has inconclusive endometrial sampling and high risk for still high risk for endometrial cancer. Now, there are some women who just simply cannot have the endometrial sampling, and especially for these women who are obese, and also having nulliparity as their background. They would have a very stenosed cervix, which will not allow for the endometrial sampling with PPAR biopsy to be undertaken. So if you have difficulty like that, you should refer the patient to us for us to do a little bit of manipulation, either with repeat endometrial sampling, or we will subject the patient to hysteroscopy and DNC. So what do we do for recurrent postmenopausal bleeding? It's quite a simplified diagram to show us what we do. If this woman never had any hysteroscopy before, after the initial postmenopausal bleeding episode, we should or arrange for them to have hysteroscopy or saline infused sonography with or without endometrial biopsy. Now, the best thing would still be to look into the endometrial cavity with hysteroscopy, because, as we say earlier, if there's any early endometrial cancer that is occupying less than 50% of the area, these type of cancer may be missed. Now, ideally, hysteroscopy should be done with the directed biopsy, where you see the polyp or the abnormal endometrial area. However, that would require a little bit of cost, where you have to buy a resectoscope, where you can manipulate and enter the forceps to resect the polyp under direct guidance, instead of doing a hysteroscopy, withdraw the hysteroscopy and do a blind DNC. So if the woman has already had the hysteroscopy and it's more than 12 months since the investigation, it will be something that you have to look into and do a repeat hysteroscopy or saline infused sonography with or without the endometrial biopsy. If it's more than 12 months if it's less than 12 months, we just have to make sure we reassure the patient, and also, unless there's any change in the symptoms, or obviously if the endometrial thickness is changed, then you would have to subject the patient to further investigation with hysteroscopy and saline infused sonography. Now, in this type of woman with recurrent postmenopausal bleeding, the likely pathology would mostly be endometrial polyps. So for asymptomatic thickened endometrium, what do you do? Sometimes you might have some woman presenting with, or especially this kind of apply more to ourselves, but you might not be in clinical setting or GP setting. You might have some woman who's had screening for any reason, to do any for a well woman clinic something, and then they just found out that there's thickened endometrium more than 5 mm. Now, it can be quite common. Up to 17% of postmenopausal women would present with this issue. So what do you do with them? Most of these women would have polyps, and if you biopsy the polyps, the risk of malignancy in these polyps will be quite low. So you do not need to trigger any additional investigation or evaluation unless the patient has comorbidities and the risk factors that we mentioned before, such as obesity, diabetes, hypertension, use of hormonal treatment, and etc. Now, having said that, there is a paper that I've read earlier, but I didn't get put in this slide, unfortunately. So what they do is they compare the ones that is diagnosed with endometrial cancer, and they see if this woman presents with postmenopausal bleeding versus not having postmenopausal bleeding. The actual outcome for these two groups are almost similar. So as a baseline or take-home message from this slide is, although endometrial cancer is something that you have to worry about with thickened endometrium, the postmenopausal bleeding would still be the best time when you are going to investigate them and do the appropriate sampling and investigation thereafter. Instead of picking any random thickened endometrium and do the biopsy and hope that you will find endometrial cancer, because they will always end up with similar outcome later on in terms of staging and their survival. Okay, so another problem, big issue with us and you alike in clinical setting. What do we do with inconclusive endometrial sampling? Now, as we mentioned before, when we do endometrial sampling, there's always a technical issue. Unfortunately, this will affect almost 16 to 50%. So there's a wide range of numbers there that I've just thrown to you there. The problem with inconclusive endometrial sampling is whether you're doing the right sampling. So If the cervix is very stenosed, you cannot introduce the pipal biopsy. If you've already been familiar with pipal biopsy catheter, they're quite soft. It's meant to be just sliding just enough. But for stenosed cervix, where the pipal biopsy will be too soft to get in, you need to be quite watchful, because again, I've already upgraded my slides in the recent time, but unfortunately it cannot be uploaded for some reason. But anyway, what it says is, do not be deceived by the fact that technical difficulty or insufficient material makes you feel reassured, because there is one of these study to show that although about 20% of women has technical difficulty and or insufficient material, they end up subjecting this woman to hysteroscopy, and I think it's about 30% of them comes with endometrial cancer. So again, for yourself in clinic kesihatan, if you think you do not have enough to suggest that there's any good sampling taken, or as in the result doesn't come back as proper benign polyp or inactive endometrium, just refer to us, because we will have to further investigate this woman with hysteroscopy and DNC. Okay, so just to bear in mind that endometrial hyperplasia with atypia or cancer are more likely to be found in women with high BMI. So again, don't be reassured, and especially in presence of all these risk factors that we mentioned before, we need to make sure that we investigate further. That's all for now. These are my references. I would welcome any question from the audience if you have any.
If you have any question, you can start typing. Maybe we can give 1 minute or and a half.
Now, actually, there's another slide that I want to show in Dr. Noxifen. Unfortunately, women these days would be on the tamoxifen for life. Actually, used to be that the tamoxifen is given only in up to 5 years after the initial presentation with breast cancer. However, these days they have more evidence to suggest that the longer tamoxifen, the better for outcome for the woman. So you will encounter women with tamoxifen use in your setting. So what do you do about it? Basically, what did they say is, we have a question there. Is there any prevention for endometrial cancer? I think the bottom line message is our population is getting bigger in terms of numbers and their size. So again, prevention is better than cure. You make sure you have to control their obesity, so there will be subsequent control about their diabetes and hypertension. But what do they do? Do you want to give them hormonal treatment or progesterone to reduce the risk of postmenopausal bleeding or endometrial cancer? Now, that is quite theoretical. I suppose these medications don't come without. They actually have some side effects to it. So you don't. Again, compliance is always an issue for you if you are to give the woman regular progesterone to prevent them from having endometrial cancer. So I would say still prevention is better than cure in terms of addressing their risk factors. If they are obese, bring down the BMI to normal. If they have diabetes, control them so it will not be out of control. And you would also have to screen for people who's having risk factors in the family, such as the strong family history of breast cancer and gynecological cancer. So these type of women, it may not be a harm to refer them to us to see if there is anything that we can do in terms of screening them for a thickened endometrium. Maybe there's a role for endometrial sampling if they have significant risk factors, although they don't come with bleeding.
So second question for Dr. Azura from Munira. If a menopause patient had postmenopausal bleeding and we did a PPL sampling, came back as atrophic endometrium, and still have persistent postmenopausal bleeding, what is the suggested treatment?
Remember we were just going through about the recurrent postmenopausal bleeding slide. So recurrent means the postmenopausal bleeding recur within less than 12 months after the initial workup. So if you've already had the PPL sampling to say there's atrophic endometrium and they still have persistent postmenopausal bleeding, so it comes to back to your assessing the patient's risk factors. You know that if there's any significant risk factors such as diabetes, hypertension, obesity, and use of hormonal treatment such as tamoxifen, you have to make sure that these are the red flags to say, although you might be falsely reassured by the atrophic endometrium, it may be no harm that you refer these patients to us, that we might be able to do hysteroscopy and have a look at what are the causes of postmenopausal bleeding in this woman. I mean, if the woman still have those risk factors, what am I saying? I'm thinking about this now. Having said that, if you have atrophic endometrium, we have to remember the gynecological cancer that we are talking about could not just be from endometrium, could still be something to do with ovarian or vulval or vaginal. So although you might say endometrium is not the cause, just bear in mind there's still a cervix there, there's still vagina and the vulva to cause us, to alarm us about other gynecological cancers. So there's no harm to refer them to us. And
the third question, maybe the last question for this session. Good afternoon, doctor. For premenopausal women with breast cancer on tamoxifen therapy, what is the cutoff point for the endometrial thickness?
This is a very, very good question, and as always controversial. That's why I wanted to put in that tamoxifen slide, but it's okay. The reading is still there. I hope I can still recall what is the problem just now about the evidence that are there available in the literature. So this question is about premenopausal women with breast cancer. Now the problem with premenopausal women is you have to make sure if they are on tamoxifen. I mean, tough question this, because premenopausal with breast cancer, it's almost certainly that they have to ask us to surgically induce the menopause in this type of woman. Okay, so what we do is by saying that when we do surgically induce menopause is we're going to take away the ovaries. So by right, the ovaries should not be working and produce more hormone to stimulate the uterus. So in that situation where you have surgically induced menopause for this premenopausal woman with breast cancer, then you have to take them for the pathway of investigation as in the postmenopausal woman, as in the ovaries already not working. For women with premenopausal woman breast cancer that doesn't have surgically induced menopause can be a little bit of a challenge, because the tamoxifen will always still working on their uterus. On top of that, you will have the ovaries to stimulate and do all the works on the endometrium. Cutoff wise, I have to say 2 centimeter will be acceptable for any woman in their premenopausal stage. And the fact that tamoxifen can increase the endometrial thickness by causing cystic changes, then it's very hard for me to say I want to change the cutoff to 2.5 centimeters. Now, obviously, with any of these hormonal treatment, you have to go back to their symptoms. So if they don't have any premenopausal, cannot be premenopausal bleeding. Sorry. I still, this one tricks me a little bit. For premenopausal woman, you need to realize or see what the pattern of their bleeding is. So if you say they are normally bleeding 7 to 8 days per month, and since on tamoxifen they bleed 14 days, then that will be change of their symptoms. So this woman should be subjected to investigation. Now, obviously, the cutoff of I'm going back to this cutoff of endometrial thickness. I cannot say. I would still stick to the acceptable majority mid-cycle 2 centimeter, and lesser than that will be towards the end of their cycle or early of their cycle. So I will leave it at that. If that is acceptable for QZ, for my answer to your question.
Okay.
Thank you very much, everybody.
Okay, thank you very much, Dr. Azura.